Bismillah ar-Rahman ar-Rahim. Now we are going to the second day of the first wave of our virtual meeting. Thank you for all speakers yesterday. It was very successful day, and I hope today will be also more and more successful. Today we have 5 lectures. The first one will be given by Professor Antonio Cerello. The second one will be given by Francesco Cosentino. The third one by Neboja Lalik. Fourth one will be by Professor Brahim Lebrashi. And finally, AstraZeneca meeting by Professor Khalifa Abdallah. I'm also happy to announce that we have the accreditation from the American Association of Continuous Medical Education, which will be given to all the members who attend these 2 days of our meeting, DGIS, and we get a very good score for this accreditation. Now I am very honored to introduce the first speaker, Professor Antonio Cerello. We all know Professor Antonio Cerello before. He will discuss today the current guidelines in the management of cardiovascular disease in diabetes. Yesterday, we discussed this point or this issue from cardiological point of view. Today, we will discuss it from diabetological point of view. Professor Cerello, please.
Thank you for the... It's okay? Can I go? Okay. Thank you for the kind introduction, and it's really a pleasure to be back today, and also to give a different point of view on the current guidelines. It's more a diabetologist point of view compared to the cardiologist point of view we had yesterday. These are my conflict of interest. So you know that in the last years we got so many trials showing the effect of the so-called new treatments for the diabetes, meaning DPP-4 inhibitors, and SGLT2 inhibitors, and GLP-1 receptor agonists. And at the end of the day, we are still waiting for some. But I think that we have already enough data to say that at least for 2 classes of compound, the SGLT2 inhibitors and GLP-1 receptor agonists, the evidence is there. They are very good in protecting cardiovascular system. This is true for both SGLT2 and GLP-1. And moreover, for particularly for SGLT2, there is a strong evidence of really a optimal action in preventing heart failure, something that is not given by GLP-1 receptor agonist. And you know that based on this evidence, the European Society of Cardiology and the European Society for the Study of Diabetes, they had a joint. They built joint guidelines. I had the honor to be engaged in the development of these guidelines on behalf of the ESD, and this was a very hard job. And I think that one of the most interesting news of these guidelines is the kind of how we identify the cardiovascular risk categories in patients with diabetes. You know, there are a lot of algorithms, particularly the most used, for example, is the UK-PDS engine, to define and to calculate the risk for cardiovascular disease of a person with diabetes. They do not work, particularly because they are not very useful for clinical practice, requiring a lot of time to be developed. While this new classification, trying to stratify people with diabetes in 3 categories at very high risk and moderate risk, in my, but also it was the opinion of the panel, offers something very interesting, meaning the very easy approach to identify the category of the risk to which a person with diabetes is exposed. And you know that regarding the guidelines, the suggestion was that if somebody is already on metformin, then you have to think about the presence or not of a cardiovascular disease, or if somebody is at high risk for cardiovascular disease. In this case, the suggestion is to add to metformin an SGLT2 inhibitor or a GLP-1 receptor agonist. And this was almost independent from A1C level. Similarly, the algorithm, the DGIS algorithm, which was published a few months later over the ESC-ESD guidelines, kept the same position. If somebody is with a well-established cardiovascular disease or is at high risk for cardiovascular disease, again, the recommendation is to use preferentially or mandatory, in my opinion, a drug like SGLT2 inhibitor or GLP-1 receptor agonist. And in this algorithm, you see that there is a much better defined that if the cardiovascular risk is predominant, so the GLP-1 receptor agonist probably has to be preferred, while if a heart failure or a chronic kidney disease is the predominates, so the suggestion is to particularly use an SGLT2 inhibitor. So regarding what to do when somebody is already on metformin, the two positions are really consistent. Add to metformin an SGLT2 inhibitor or GLP-1 receptor agonist independently from the A1C level. However, of course, there is a different situation when somebody with diabetes is drug naive. So you discover diabetes, and there are at least 3 situations in which this can happen. And you have somebody when you start a therapy where the lifestyle change is not enough, the person is CVD-free and not a high risk for CVD. But also you can have the situation that the lifestyle change is not enough and the person is at a high risk for CVD, or very often, and this is very often reported, honestly, by cardiologists, you have the situation in which diabetes is discovered after an acute and established cardiovascular event. So the cardiovascular event is the occasion in which diabetes is discovered. Clearly, okay, these are all conditions you can find in drug-naive person, but they are very different in terms of perspective. And if you look at the new DGIS algorithm, this situation is quite, let's say, unclear in my opinion. Why? Because the suggestion is that if you have to start anyhow, you have to start with metformin. Okay, but what about if there are different situations? What about if you have somebody, for example, at high risk for cardiovascular disease or with an established cardiovascular disease and then you discover diabetes? Are you starting with the metformin? There is probably the case to think that instead of metformin, you can start with something else. And you know that there are some evidence suggesting that probably this is the best option. Why we're using metformin as background therapy in large majority of patients? That's also the case of the CVOT trials. Many patients, they have metformin as background therapy because there was an evidence coming from UKPDS, and I will come very soon on this point. There were some evidence coming from some small studies. However, the key study suggesting to use metformin as a starting therapy is the postdoc is a sub-study of the UK-PDS. In this sub-study, people with overweight were treated with metformin, and in this case, there was a significant reduction of myocardial infarction. And to be honest, this is also the case in the long-term follow-up with UK-PDS. Again, metformin was confirmed to prevent myocardial infarction in this subgroup of people. Honestly, we are speaking about 342 people. So it's not a so huge amount of patients to justify that this is true for all the patients with type 2 diabetes, particularly in people without being not overweight or obese. In this direction, we have some meta-analysis. If you look at the left side of this slide, you see that in this meta-analysis, the protective effect of metformin on cardiovascular disease was not confirmed. It was found neutral. There is only one meta-analysis suggesting that metformin may have a protective effect on cardiovascular disease, but this is methodologically incorrect. Why? Because it was pooling randomized control trials and real-life data, which scientifically is not correct. Anyhow, many other meta-analyses were unable to confirm the role of metformin in preventing cardiovascular disease. You know, one of the issues, raised by the fan of a metformin starting therapy was that in any CVOT trial, people were having metformin as background. So was supposed not to be clear if adding a new drug was requiring metformin in order to express its ability, or without metformin, this drug, anyhow, they would have worked in protecting the persons. And we have already some evidences in this field. For example, in the EMPA-REG outcome was shown that the effect of empagliflozin in protecting from the cardiovascular event was completely independent from the presence of metformin. So there is this idea that metformin was the key player when you are adding an SGLT2 was not supported by data from EMPA-REG, but also from data from CANVAS. Also in the CANVAS, the patients not receiving metformin had a significant reduction of the cardiovascular disease when treated with the canagliflozin. And this is why in the SCSD guidelines, you find that as a starting therapy in drug-naive patients, when a cardiovascular disease is already established or the people are at high risk of cardiovascular disease, the recommendation is to start the therapy with an SGLT2 inhibitor on a GLP-1 receptor agonist. However, there is an interesting news, in my opinion. If you look at the algorithm, the algorithm, already you find this statement that we now suggest that probably initial combination in the new onset cases of diabetes might be considered. And this is why we have recently suggested that it probably is the time to harmonize a glucocentric and a cardiocentric view of diabetes management. You know, the VERIFY study confirmed that starting immediately with the combination of metformin plus a DPP-4 inhibitor, the vidagliptin in this case, was really successful in preserving beta cell function and glycemic control over time when with the combination was compared with the starting with the single drug, meaning only metformin and vildagliptin. So in our opinion, the idea is that it's time, and probably this will be considered the next guidelines in a more extensive way, is the case that is at this time to start the therapy with of diabetes with the combination therapy, considering that the glucose control anyhow is important in diabetes, but at the same time is very also important to prevent cardiovascular events. So the idea, the suggestion is that if there is no risk for cardiovascular disease, you can start with metformin in combination with the DPP-4 inhibitor, but if there is a risk of cardiovascular disease, you can start immediately with a combination of metformin plus GLP-1 receptor agonist plus SGLT2, waiting for the new data which are evaluating if the combination between a GLP-1 receptor agonist and SGLT2 inhibitor is really more protective against cardiovascular disease than each drug alone. So probably this will be soon a new paradigm for the diabetes management. So in conclusion, we can say that cardiovascular disease is the leading cause of mortality in diabetes. However, we cannot forget how important it is also to avoid the microvascular complication of this disease, and how an early continuous optimal glycemic control remains the best strategy. So it seems that it's time to harmonize both the glucose and the cardiocentric approach as the best strategy to reduce the burden of the complication of diabetes. Thank you very much for your attention.
Thank you, Professor Aurelio, for this very clear illustrative lecture about the diabetologist's point of view in treating type 2 diabetes. I think still metformin has its place in the management of these patients. We can also put in our mind patients with high-risk cardiovascular problems and established cardiovascular disease to remember the new tools that are reducing the risk of this complication. Thank you again, Professor Aurelio. Ahmed.
I am honored to be with you in the second day of the Diabetes Guideline Implementation Summit, DGIS. And I want to tell you something that at present, it's well established that management of cardiovascular disease and diabetes is an important component of the comprehensive management of the disease. So the importance of managing the CV risk in diabetes. Professor Francesco Cosentino will be in the next 20 minutes, will be discussing some of the unmet needs in managing CV risk in diabetes. You are welcome, Professor Cosentino.
Thank you. Thank you very much for the invitation. So in order to address the topic of my presentation, I mean, these are only my disclosure. I would like to start by discussing several aspects, starting with the diabetes and cardiovascular risk, to move to the impact of target-driven management and the residual risk despite management, and then ending up with a few words on how we can close the gap that still exists. So let's now address the first point, diabetes and cardiovascular risk. If we look at the global mortality, as it has been attributed by the World WHO organization, has attributed global mortality to 19 risk factors, and this has been done according to country income levels. Now, if we look in more details, you can see that risk factors such as high blood glucose, physical inactivity, overweight, and obesity are ranking very high in this scale, and we know that all them are related to and common in patients with diabetes. So without any doubt, diabetes is one of the major leading causes of mortality worldwide, and we know that it becomes even more important in the presence of other risk factors. Here we have the mortality risk in patient with versus patient without diabetes, and this is the left panel of this slide. You can see that in patient with diabetes there is a higher risk for cardiovascular death, 2.5 increase in cardiovascular death, and the same it is true for all-cause mortality. And then we learn that the estimated years of life lost due to diabetes is consistent both in men and in women. And it is appearing that if you start early in your, let's say, diabetes career, in your disease trajectory, I mean, if you start to have diabetes when you are in your 40, 50 years of age, you see that men lose almost 6.5 years of life, and even more for women, 7 years of life. But then if you instead are old when you start to have diabetes, the overall risk is not that large. So this has to be taken into consideration, because actually young women with diabetes are at particular risk, because diabetes takes away their female privilege of being protected from cardiovascular disease until the age of menopause, as we know. So it is very important to protect patients with diabetes, because they lose a substantial amount of years if we don't help them. Now, more recent, more modern data. Here we have data from the Scottish Diabetes Register, recruiting patients with type 2 diabetes, more than 270,000 patients, compared to controls from the population. And this study made a step forward, because this was stratified according to socioeconomic status. And the period of this observation was 2 years. And you can see that there is the same pattern of years of life lost due to diabetes, both in men and in women. But in the people who had the worst socioeconomic status have an increase in years of life lost. So interesting observation. I mean, we know that the concept of clustering of risk factors is very well known, well established. Here we have an American studies looking at the continuum of the combination of different risk factors and the risk of die for coronary artery disease. As we see here, in patients without diabetes, the gray line, if we move from a systolic blood pressure level of 110 millimeters of mercury up to 160 millimeters of mercury, and the same also if we have moved from 4 millimole liter of serum cholesterol after to 7 millimole liter, you can see that there is a linear relationship, a linear increase in the risk of dying for coronary artery disease. And the same linear relationship is present in patients with diabetes, but at much higher level. So for a patient with diabetes, a certain blood pressure or cholesterol increase means much more for the risk of developing and dying of coronary artery disease. Now, based on this, we have to consider the multi-factor risk pattern. I mean, it has been calculated that all patients with diabetes, of course, 100% of them have dysglycemia, but 90% of them are also overweight or obese, 70% have dyslipidemia, and 66 of them have concomitant presence of arterial hypertension. Now, when we look at and we consider the principle for management, if we have a multifactorial cause to the problem, we have to search a solution with multifactorial intervention. And this brings me to the next part of my lecture, which is the impact of target-driven management. And when we consider target-driven management, I can cite the European Society of Cardiology guidelines, which were presented in September last year at the ESC Congress, and then they were published in the beginning of this year on European Heart Journal. We basically know that extremely well that we should try to lower glucose with individualized targets. We also know that we should protect the patient from having too sticky platelets, because to have sticky platelets favor the development of thrombotic events, and so we need to implement antiplatelet therapy. And we also know that we have to control blood pressure and lipid, and we know that nowadays the lipid targets are more ambitious for very high risk patients. We have to reach a target of less than 1.4 millimole, which is less than 55 milligram per deciliter in very high risk patient in secondary prevention, patient with diabetes in the secondary prevention setting. All this target-driven management as the backbone, the background base on lifestyle modification, because we know that physical activity, proper diet, and no smoking is really the fundament for the treatment of patients with diabetes. Now, let's look at some trial data. What does it mean with risk factor control? And when we ask ourselves the importance of risk factor control, we have to cite the STINO2 study, which is a classical Danish study. It was performed in relatively few patients at high risk, because this study recruited patients with diabetes and microalbuminuria, and the patients were randomized either to an intensive treatment, which means very intensively treated in terms of blood pressure, lipid, everything you can imagine, intensive arm of the study. And then there were another arm of the study, which the patients were left with rather a conventional treatment. This treatment went on in the intensive and the conventional arm for almost 8 years. And then there was an observational phase of this trial, which continued for 30 more years. So 20 years, the observation study was 20 years all in all. And if we look at the patients which were survived without any heart failure or myocardial infarction, which is depicted here in the green area is much larger in the intensive therapy group as compared to the conventional therapy group, in which the percentage of patients free from heart failure and myocardial infarction was significantly lower. And the same also if we consider the individual endpoint, myocardial alone or heart failure alone, you can see that this green area is the other areas are bigger. So the percentage is higher in the intensive therapy of patients free from these events. So basically, aggressive multifactorial treatment really makes sense in the long run, because this was a 20 years follow-up. Now, the authors of this study look also at the prognostic importance of different risk factor reduction using the UK PDS risk score. And as you see here, the lipid control is the most important for risk reduction. And then we have glycated hemoglobin and systolic blood pressure. Smoking, very little relevance, only because I think the investigator in this trial had a hard time to make the Danish quit smoking. Now let's look at some population data. Here we have on the importance of risk factor controls in type 2 diabetes. Here we have data from the Swedish National Diabetes Register. We have more than 270,000 patients with diabetes, which were matched for age, sex, area of residence with controls from the population, a follow-up of approximately 6 years. And this study looked at the trend in death, myocardial infarction, and stroke. And if we look at the excess mortality in relation to risk factor control, you can see that in the control population, a different age group, from age group above 80 years of age down to less than 55 years of age, you can see that the control population had a reference value of 1. The risk for them to develop excess mortality is equal to 1. And then if we move down, here we have the patient with well-controlled risk factors. So you see, if you are able to have a well control of different risk factors, you are able to bring the risk for excess mortality to 1, almost in every age groups. And this is very important. But look what happens if this does not happen. If you have 3 risk factors which are badly controlled, or 4 or 5, you can see that there is a significant increase in the hazard ratio for excess mortality. So this is very important because it's underlying the importance of controlling risk factors in order to prevent mortality. And the same pattern is observed also for acute myocardial infarction and stroke. You can see that if you have a poor control of risk factors, the hazard ratio for the risk of MI or stroke is increasing. So in conclusion, there is considerable risk reduction with combined risk factor control in type 2 diabetes. Now, let's talk about residual risk, because if this would be the case, there should not be any residual risk if our patients are well controlled. But here, what we see data from another Swedish register, the Sweetheart annual report on 1-year mortality after myocardial infarction in all MI below the age of 80 in Sweden from 1995 to 2016. And you can see that the 1-year mortality in all this period of years has been reduced by the implementation, as we know, of very important treatment strategies. But still, despite this reduction, there is a 30% gap between patients with diabetes versus patients without diabetes. So this gap is a very bad thing, because we need to get rid of it. Here we have population data looking at residual risk after myocardial infarction in terms of all-cause death, cardiovascular death, coronary death. Again, you see that the blue line are patients with diabetes, and the red line are controls from the population. And there is still a clear-cut gap, which should not be there, because we have the possibility to intervene. So then it comes the next question. What are the possibilities to close this gap, which is still existing? And one remedy is improve management. And if we consider that, I want to show you that what we achieve if we follow guideline treatment goals in terms of cardiovascular prevention in patients with type 2 diabetes. And this is data from the US. And you can see that up to 50% of the United States patients with diabetes do not meet the targets for glycated hemoglobin, blood pressure, and LDL cholesterol level. And the same holds true on this side of the Atlantic. Here we have data from a European Society of Cardiology array, the EURASPIRE, European Action on Secondary Prevention Intervention to Reduce Events. And here we look at the proportion of patients reaching different LDL cholesterol target or different glycated hemoglobin target according to the diabetes status. So we have patients without diabetes, patients with newly diagnosed diabetes, and patients with known diagnosis of diabetes. And you can see that the proportion of patients reaching either LDL cholesterol target or glycated hemoglobin target is very poor. So there are a lot of things to be done to implement in the real world what is in the guidelines. So we have a considerable improvement potential to carry on. The other option we have is to add in new powerful pharmacological tools which have proven to have cardioprotective effects. And as it was shown by Professor Ceriello before, we have performed many trials testing the effect of newer glucose-lowering drugs in patients with type 2 diabetes. All these trials were initiated after the FDA EMA requirements that requested that each newer glucose-lowering drugs had to be cardiovascular, to prove to have cardiovascular safety. And a huge number of patients have been, as of today, recruited in this trial. We are talking approximately of 180,000 patients. And as it was said, many of these trials have been concluded, and we have obtained the results that drugs such as SGLT2 inhibitors and GLP-1 receptor agonists are protective and in terms of cardiovascular events. But then let's look at the situation in terms of what is the actual practice in glucose control. These are unpublished data from the EURASPIRE, from this survey of the European Society of Cardiology. And you can see that the use of glucose-lowering drugs such as GLP-1 receptor agonists and SGLT2 inhibitors is very low today, despite the fact that we know that by using this drug, we may have an impact on the cardiovascular events of our patients with type 2 diabetes. So there is a big gap in our way of using novel glucose-lowering drugs to save the lives of our patients. Now I would like to conclude just presenting you a major paradigm shift in the management of patients with type 2 diabetes. Before 2008, the dogma was glycated hemoglobin, the lower, the better. From 2008 on, yes, the lower, the better, but without engaging in weight gain, without producing and causing hypoglycemia and side effects. And in the last couple of years, cardiovascular risk management is important, including blood pressure, LDL cholesterol, glucose lowering with agents of proven safety and efficacy. So if we have to consider and try to summarize the preventive strategies, what we have learned in the last decade is that many factors contribute to increase cardiovascular risk in patients with diabetes. So we need a multifactorial approach to address all these risk factors. And we need to have in mind that the treatment targets and the therapy should be individualized depending on the individual circumstances and the level of CV risk. Thank you very much for your attention.
Thank you, Professor Cosentino. You discussed elegantly the multifactorial cause of CV risk in type 2 diabetes. And you discussed the target-driven management, reduction of blood pressure, stopping smoking, and lipid therapy, lipid management, and body weight reduction. And you tried to explain how to close the gap and to manage the CV risk by discussing two important points: proper management of the risk factors and use of recent modalities of treatment. Let me ask you about the third tool. Is there a way to have a single agent or single strategy to manage the global cardiovascular risk in diabetes? And let me remind you that for the last decade, we were talking about insulin resistance, for example. Tackling or managing insulin resistance proved to some extent to be effective, but disappointingly the story is almost over nowadays. In your belief, what is the factor that in the future may be important for the management of global cardiovascular risk?
Well, I think what we have learned both from population data and trials is that if we have a multifactorial approach to the problem, tackling not only glucose, which is an important component of the increased risk factors, but tackling blood pressure, cholesterol, with the pharmacological tools we have available. But not only that, because lifestyle modification, as I mentioned, must be really upfront. I know that it's easier, both for the physicians and for the patient, to prescribe a pill and get a pill rather than to have a healthy lifestyle and proper exercise and diet. So I think, as you mentioned, insulin resistance, it can be really considered a common denominator, because all these conditions, atherogenic dyslipidemia, hypertension, high glucose, may have insulin resistance as a common root, and of course, if we fight all these conditions, we may have an impact in reducing insulin resistance and hyperinsulinemia. And that's maybe, not maybe, it is rewarding in terms of management of cardiovascular risk.
On behalf of one of the attendees, let me ask you the frequently asked and the always asked questions, although the situation is settled in the guidelines. The role of aspirin in patients having type 2 diabetes, low risk for cardiovascular disease, high risk for cardiovascular disease, but who don't have established cardiovascular disease. In one word, in primary prevention.
Yes. And indeed, this is something new in our guideline this year, because the last edition of the guideline was saying that aspirin is not appropriate in primary prevention. Whereas now, based on the results of most recent trials, which have been recruiting patients with diabetes at high CV risk, but without established cardiovascular disease. And these trials have shown that there is a 12% reduction, significant reduction in cardiovascular events. So based on this trial, we recommend that there is evidence to consider the possibility of having aspirin treatment for patients with diabetes in primary prevention, provided that they are at very high risk. And these, of course, we have to consider that we increase the bleeding risk by giving diabetes. But if we weight the advantage and disadvantage in high-risk population, the advantage may be higher than the possible risk of having bleeding.
You mean that the higher the risk is,
then
the more the likelihood of using aspirin in primary prevention?
Yes, yes.
Thank you. It's my pleasure, sure, to be with you in this meeting, and I hope in next year we will be able to meet face to face. Thank you again, Professor Kudinski. Thank you. And the time is now for the next meeting. Thank you.
Thank you. Bye-bye.
Introduce Professor Nivoja from Lalik from Serbia. He is President-elect of International Diabetes Federation Europe, and also member of the ESD group of Diabetes and Cardiovascular Disease Board. Professor Lalik will going to present, is insulin resistant still relevant to cardiovascular disease? Professor Lalik.
Thank you very much for this kind introduction, and it is really great that this topic just goes after the discussion from this previous speaker and the chair of the previous part of the meeting, which also mentioned the insulin resistance and the relationship to cardiovascular disease. We were all very much fascinated some 10 years ago or more with the role of insulin resistance in the onset and pathogenesis of CVD, and we thought that we found a clue how to what was the cause and how we might cure, if not cure, then change, modify the onset and the cause of CVD. Later on, it appeared to be more complicated, and nowadays, practically speaking, we don't have the drug that acting on, except if you wish, metformin, but not to the whole extent. The agent that might modify the onset and the outcome of CVD on the basis of insulin resistance. But however, as Professor Constantino said, I will be speaking about something like common denominator that is behind the onset of CVD, and what is its clinical meaning and where it is really placed. So the task is not that easy. So sorry for a moment. Okay. So in this context, I will go through 3 parts. In the first one, I will just remind you the relationship between insulin sensitivity and glucose homeostasis, and the overall metabolic control in metabolic diseases, and especially in diabetes. Then in the second part, I would remind you also about the clinical relevance of insulin resistance and CVD, based partly on our own results. And finally, I would do an attempt to bring up some more recent information, how insulin resistance can facilitate CVD and what are the possible mechanisms. So let's start from the beginning. You know this picture, of course, very well, and this is the regulation of the glucose level and in the fasting state in the normal environment. And you can see that insulin secretion is at the basal level, and that glucose comes mostly from the liver. and that everything is keeping the blood glucose within the very narrow range. What happens with if the food comes in, then of course blood glucose has a trend to increase. Then insulin secretion reacts, and then it acts at many points, but especially on the liver and on insulin and fat, and these are the tissues that are insulin dependent. And the outcome is that glucose comes back to normal if insulin is active to the extent that it can exert its biological role. In other words, if there is no insulin resistance. So that is basically how the insulin resistance was discovered. But later on, we found out that there are many other aspects of the whole thing. And one is, for example, that when you plot insulin sensitivity to insulin secretion, you can find, as Bergman has shown many years ago, this beautiful curve in which if insulin sensitivity increases, then insulin secretion goes down, and the vice versa. But however, it appeared to be that in some metabolic state, this curve can be displaced, and here our headache starts. Can be displaced down in a way that insulin secretion cannot compensate so beautifully to the needs of the derangement of insulin sensitivity, and that which we can see in obesity and in type 2 diabetes especially. If you then, if you went to the molecular level, this is when insulin binds to its receptor and starts its signaling pathway through insulin receptor substrate, of course, and through many other levels, and to ACT, which is a very important crossroad, leading in normal circumstances to many important functions. And this is glucose uptake, this is glycogen synthesis, and this is, of course, the inhibition of gluconeogenesis. It appeared to be that if we have within the cell the accumulation of the acetylglycerol and activation of protein kinases, you can have an inhibition on the level of IRS. If we have the activation of inflammatory cytokines, pro-inflammatory cytokines, you can have the same thing in the overall picture. I mean, the inhibition on the level of IRS, which stops or decreases the future pathway to ACT. On the other hand, the accumulation of ceramide and their products can act on ACT and have induce the same type of impairment, resulting in less glucose uptake, in less glycogen synthesis, and in uninhibited gluconeogenesis. So this happens, of course, in many, it appear to be, metabolic states, especially in type 2 diabetes and obesity, but also you will see at this slide that the same course of events can result in activation of MAP kinase pathway, which would amplify the inflammation and can go and amplify and can also amplify the small muscle proliferation and lead up to atherosclerosis. But however, what is also unfavorable, the inhibition of ACT, here is ACT which is not inhibited and which preserves the vasodilatory capacity of the arteries. Now this effect is gone, and you will have the problem on the level of arterial wall. This here starts the connection to the cardiovascular disease in diabetes and without diabetes as well. So this was just a sort of a recall of the possible pathogenesis and of the insulin resistance and how it can influence on the cellular level the cellular level the atherosclerosis. But however, it is evident, and from the very early days, that you can show and that insulin resistance can go with and correlate and be associated with cardiovascular disease in many circumstances. This epidemiological study that has, which is very well known, by 2002 has shown that insulin resistance measured by HOMA can then be correlate and be goes in the same direction as 8-year-old risk of cardiovascular outcomes, which was sort of beginning of the interest. How and to what extent in the clinical settings you can demonstrate the influence of insulin, the influence of insulin resistance. And in our own hands, we did a number of studies, mostly in people with type 2 diabetes. And we have shown, of course, that the insulin sensitivity measured by the insulin, by hyperinsulinemic euglycemic lamp has revealed that insulin sensitivity is, of course, lower than normal controls. But however, we saw that in patients, type 2 diabetic patients with the coronary artery disease, we had lower the total glucose disposal in comparison to those ones who, by the same in accordance to the same duration of diabetes, did not have the same thing. We verified that with using another model, minimum of exploring insulin sensitivity, minimal model, that has shown pretty much the same results. This is diabetes plus CHD. This is diabetes without CHD. And we have confirmed the same results in non-diabetics, showing that CHD goes with lower insulin sensitivity. And we then tried to do just a simple study of that time, using try to plot and correlate the insulin sensitivity to SI index in minimal model. And to our surprise, we found a good correlation between the severity, as we call it, of the number of stenotic artery diseases and insulin sensitivity. I mean, inverse correlation. And finally, we measured the myocardial reinfarction versus infarction in the context of insulin sensitivity measured, insulin resistance measured by HOMA. And we found that in both in type 2 diabetics and non-diabetics, those having reinfarction, having multiple myocardial infarctions, had higher HOMA ER than in comparison to those ones who had just one myocardial infarction. So the clinical, let's say, evidences were there. We were one of the tens and tens of dozens of groups that worked in this area, and definitely it played an important role influencing cardiovascular disease. But then in the context of all other things that were mentioned, other risk factors, and the relationship of insulin resistance to those risk factors, now the question came: what are really the possible mechanisms that of insulin resistance facilitating the development of cardiovascular disease. And we came in to some rather complicated scheme that we have here. Maybe insulin resistance as somewhere in the background, causing all these intracellular changes that I mentioned, activating the MAP kinase pathway and leading to these changes that were proven to be associated with insulin resistance, like endothelial dysfunction, decreased NO production, increased ET1 production, and so on. So if we put it, this is about insulin resistance without taking into account diabetes and its hyperglycemia. And if we just put that on one scheme, you can have this glucose binding to the insulin receptor, and depending on, in fact, the relationship of these two pathways, you will have either vasodilation or vasoconstriction, and the pathway towards increased atherosclerosis or the prevention of it. But what are really the relationship between each of the steps in this cascade, especially in the context of diabetes? In the context of diabetes, the thing is even more complicated, because apart from insulin resistance, you have also hyperglycemia. And if we envisage that on the left side of this scheme, you have the effects of hyperglycemia as itself, and on the right side, you have the effects predominantly of insulin resistance. You can see that that there are many things important for development of cardiovascular disease that are on both sides, but a number of those predominantly placed on the side of insulin resistance. First of all, there is endothelial dysfunction that is stimulated by both hyperglycemia and insulin resistance, and that it is really associated with insulin resistance. We did a study with the intracoronary so-called acetylcholine test, intracoronary test, which showed the possible constriction or paradoxical vasodilation of the coronary arteries with our fellow cardiologists, and have seen that the response to this acetylcholine test correlated with the level of SI, which means of insulin sensitivity. And that which was sort of a local argument that insulin sensitivity plays an important role, not only on the systemic risk factors, but also on the local risk factor on the level of the heart vasculature. Then, of course, you can find this free radicals on both sides, and that can be induced by the present situation. And in this context, we try to see in the periphery, at least, antioxidant enzyme activity and insulin sensitivity in type 2 diabetes patient. And we found something which was a little bit surprising, that first of all, it's correlated both of the enzymes of the antioxidative pathway correlated with the changes in total glucose disposal, of the changes of insulin sensitivity. But however, in diabetes as itself, although it is the situation in which the circulation is full of oxidative oxidants, the response is decreased in comparison to the controls. So it appeared to be as if there is some inhibition of the response, which correlates with insulin sensitivity and which remains to be explained. The thing which is also in common for insulin sensitivity and for hyperglycemia are the changes in the level of PI1 and fibrinolysis, which was very easy to find. And in our hands, this changes in PI1. PI1 levels were the highest when both diabetes and cardiovascular disease was present, and then it was like a picture in the mirror regarding in comparison to insulin resistance. There was the highest glucose disposal. It means the lowest insulin resistance in the control group, and definitely the lowest one, the insulin expressed insulin resistance in the group having diabetes plus CHD. And when we even tested the daily profile of type of PI1 during the day, it in people with insulin resistance, it was flattened, it was lost in comparison to those ones who did not have insulin resistance. It correlated with insulin resistance. Then, regarding the adipose tissue, of course, there are many adipocytokines, but adiponectin is something which is mentioned very frequently, and in order to maybe be protective and decreasing cardiovascular risk in obesity, enhance in diabetes, we got that type of picture showing the relationship between adipokines and HOMA-IR, which is, as you can see, which is the opposite. If with the increase of adiponectin, there is a decrease in HOMA-IR. And finally, the lipids, and we were interested in small dense LDL, and in this context, we found that LDL particle size was an independent predictor of endothelial dysfunction and correlated with insulin sensitivity changes. It was lower in those ones who had lower insulin sensitivity. If we would like to put all the things together, we can say that in the light of the very recent findings, maybe it is something that should happen before insulin resistance, and this is the changes in the adipose tissue or the amount of overweight, as the authors of this scheme suggested. And that has a very important influence on the onset of insulin sensitivity, which affects very vigorously the onset of prediabetes and development of diabetes, and to a lesser extent the development of CVD or macrovascular disease. Whether this is the place of common denominator, we don't know, but the final place. But it is really there is a need for more studies, but however, or maybe to synthesis of the results that came in after now. And finally, this is my group, and best regards from Belgrade, from the place where I work. Thank you very much.
Thank you, Professor Lalik, for your elegant presentation. Does this get us back again to the use of insulin sensitizers in reducing cardiovascular events, especially the proactive of the pioglitazone was already, secondary endpoints was successful, but the primary endpoints, which including some form of the peripheral vascular disease, don't make it superiority. Do we have to need to go back again to the insulin sensitizers?
I don't know what to tell you because in a way, yes, but insulin sensitizers did not offer this range of possible effects apparently to cover all the mechanisms that are under that are responsible for the development of CVD without diabetes or in type 2 diabetes. So if I think that in this context, we would need a better insulin sensitizer.
Thank you, Professor-elect, for your elegant presentation. So we're going to go to continue to the other symposium. Thank you again, and hope to see you in Egypt.
Now to the next speaker, I have the honor to introduce my dear colleague and my dear friend, Professor Ibrahim Al-Abraji. Professor Ibrahim Al-Abraji is a professor of internal medicine, diabetes and endocrinology at Aini College, Cairo University. He also occupies the position of the head of internal medicine department in the same college, and he was the ex-dean of the National Institute of Diabetes and Endocrinology for many years. Professor Ibrahim Al-Abraji will deliver an interesting talk under the title SGLT2 inhibitors versus LGLB1 agonist for diabetes in real-world study. Professor Ibrahim, could you please start?
Thank you, Professor Atif, for your presentation, introducing me. Actually, today I'm going to talk about very interesting subject. In the last American Diabetes Association meeting, a lot of data about SGLT2 inhibitor versus the GLP-1 receptor agonist. So I picked two parts. One of them is an observation study in the real world, and the other one of the meta-analysis to see what is different between the usage of this SGLT2 and the GLP-1. Actually, we need to know that patients with type 2 diabetes and established cardiovascular disease definitely are ideal candidate for either this use of SGLT2 or the GLP-1 receptor agonist. We all know that the latest American Diabetes Association clinical practice recommendation mentions that patients with established cardiovascular disease or at high risk for cardiovascular complication, heart failure, chronic kidney disease should be either prescribed after metformin as either SGLT2 inhibitor or GLP-1 receptor agonist. But given the data from the outcome trial, the SGLT2 would be a better initial strategy in patients with type 2 diabetes and heart failure, especially heart failure with reduced ejection fraction. We all know that two types of heart failure with preserved ejection fraction and one with reduced ejection fraction. Most of the data of the benefit of the SGLT2 inhibitor in patients with heart failure with reduced ejection fraction, or even diabetic kidney disease. But on the other hand, the GLP receptor 1 agonist may be better initial strategy in type 2 diabetes patients with established atherosclerotic cardiovascular disease or at high risk, as the American Diabetes Association, the latest 2020 mentioned, especially if there is concomitant obesity contributing to the disease process. So both of them is ideal after metformin. All we know now, yes, that SGLT2 in patients with heart failure or chronic kidney disease, GLP-1 in patients with obesity. But definitely the real world evidence comparing these two therapeutic classes based on the cardiovascular outcome trials is limited, and relative treatment persistence, utilization, and cause data or even less well studied. And we are going to present this study. It's an observational study presented by Ponwala, a researcher from Humana in Texas, on June 12th at the American Diabetes Association session. The investigators matched more than 10,000 patients with type 2 diabetes, half initiated on SGLT2 inhibitor and half initiated on GLP-1 receptor agonist. Well, all of the data came from the database of insurance claims. The researchers identified patients aged between 19 to 89 who were newly prescribed one of these two types of anti-diabetic agent from January the 1st of 2015 through June 30, 2017, during 2 years. The team matched 5,500 patients on GLP-1 and the same number, 5,507 patients newly prescribed SGLT2. The mean age was around 65 years, and most of them have 53% were women. 1/3 had established atherosclerotic cardiovascular disease, including myocardial infarction in 37% of cases, 7.9, and stroke 9.8 and 11.5, and heart failure 11.5. About 2/3 were receiving metformin, and also 1/3 receiving insulin therapy. In the GLP-1 receptor agonist group, more than half of the patients were prescribed liraglutide mainly, followed by dulaglutide, then exenatide, and only 2 patients on lexaglutide. In the SGLT2 group, from 2015 to 2017, 70% on canagliflozin, and 1/4 received IMPA, and the rest received dapagliflozin. What about the results of this observation study? During up to the 3.5 years follow-up, a similar percentage of patients in each group had either an MI, stroke, or died. This was the primary composite cardiovascular outcome, with the hazard ratio the same. However, more patients in the GLP-1 receptor agonist group had heart failure or died, which is the secondary composite cardiovascular outcome, driven by the higher rate of heart failure in this group. They found that patients on GLP-1, they have more heart failure and died of heart failure. But after adjusting the time to events, there was no significant difference between the both groups in the secondary composite cardiovascular outcomes, but apparently in the heart failure and death from heart failure. During the 12 months after the initial prescription, or first year of the initial prescription, patients who were started on GLP-1 versus SGLT2 had higher mean monthly medical cost, which including emergency department visits, outpatient visits, and very important is hospitalization. And they also had a high pharmacy cost, definitely, because GLP-1 receptor agonist is costing more than SGLT2 inhibitor. And they were more likely to discontinue treatment or to be hospitalized or visit emergency department than the patients and the group of patients of SGLT2. So GLP-1 had more cost, either pharmacy cost or general medical cost, more discontinuation, more hospitalization, and more visiting to ER. However, given the comparable effects of these two drugs types on major adverse cardiac events, the MACEs, in a similar patient population with type 2, it's not too surprising that were no significant difference in these outcomes. In the primary endpoint, it was the same. And it was also somewhat reassuring to see that heart failure rates were lower with SGLT2 inhibitor, as one would expect, because these agents have been shown to be significantly reduce the risk of hospitalization for heart failure in multiple outcome trials, where GLP-1 receptor agonist beneficial cardiovascular effects appear to be more limited to the MACE reduction. It is the 3-point MACE, cardiovascular deaths, non-fatal MI, and non-fatal stroke. So both of them in the primary endpoint, the 3-point MACE is the same, but SGLT2 definitely proved that more superiority in heart failure, and on the other side, utilization, cost, and even less discontinuation of the medication with the SGLT2. The higher rates of this discontinuation with GLP-1 receptor agonist is not surprising, since patients experience more GIT tolerability issues with this agent, mainly nausea, which can be mitigated in the majority of patients with appropriate education and close follow-up, but this is not done consistently. Similarly, the cost difference also expected. GLP-1 receptor agonists tend to be more expensive. On the other hand, the higher rates of hospitalization observed in the GLP-1 receptor agonist requires first exploration and confirmation. Why? But this may be due to residual confounding, since GLP-1 receptor agonists are typically initiated later in the type 2 diabetes patient algorithm. So this patient could have lesser diabetes duration, more difficult to manage type 2, and with more comorbid despite opportunistic matching. So that could be explaining why a higher rate of hospitalization with GLP-1 could be these patients using G1 on the later stage of the disease, difficult to treat, and also have more comorbids. And they concluded from this study, which is an observation study of SGLT2 versus GLP-1, that drug adherence, healthcare use, medical cost, and heart failure rates were better among patients with type 2 who were newly prescribed a sodium glucose cotransporter inhibitor than the GLP-1 receptor agonist in real-world observation study. The composite cardiovascular outcome were similar between the two groups, both of them the same effect on the primary endpoint, reducing the primary endpoints, the 3-point base. These findings suggest potential benefit of SGLT2, particularly where risk related to heart failure is an important consideration. But as always, any benefit needed to be weighted against any risk. But still, this study provides a pretty complete and current picture of claims. It has limitation because it's an observational study, and such a possible error or omission in the claims of that. This is the first study I'm going to present. The second study also was published in the Journal of Endocrine Society 2 months ago, talking also the same direction, GLP-1 receptor agonist versus SGLT2 inhibitor for treatment of type 2 diabetes. The objective of this study was to assist in the prescribing decision regarding severity of illness and risk of adverse events. It is a meta-analysis of the major cardiovascular outcome trials and the previous meta-analysis. They reviewed all the previous analysis to evaluate the relative benefit regarding underlying cardiovascular risk, underlying renal diseases, and relative adverse event risk profile. The individual trials definitely had differing inclusion criteria, different severity of cardiovascular disease and renal disease, and different duration of follow-up of the population. They re-evaluated the event rate regarding the underlying event rate in the control population to use this data to estimate the effectiveness of treatment strategy using existing cardiovascular risk engine and renal profile. What is the trial characteristics? There are 6 major cardiovascular trials of the GLP-1, the very famous leader of liraglutide, sustain 6 of the semaglutide, elix of the lixizanatide, excel of the exenatide, rewind of the dulaglutide, and pioneer of the semaglutide, including more than 50,000 subjects. The 4 major cardiovascular trials of SGLT2 encompassing more than 33,000 subjects whom are the IMPA-REG outcome of the empagliflozin, CANVAS the canagliflozin, DECLARE TIMI the dapagliflozin, and CREDENCE the canagliflozin. These trials of both classes, the GLP-1 and SGLT2, were similar in many baseline characteristics, including the age, nearly a mean age of 63 and 63, the percentage of women 39 and 35, all of them are statistically not significant, and the percentage of cardiovascular disease entered, 68 versus 50, and this was statistically significant. The trial difference in the duration of study for GLP-1 versus SGLT2 trials. It was more longer in the SGLT2, 3.7 years, and 3.4 years in the GLP-1. The baseline hemoglobin A1C is a little bit higher in SGLT2, 8.2 versus 8 in the GLP-1. The percentage of hypertensive patients, 92 in SGLT2, 86 in GLP-1. Of heart failure, the heart failure group were more in the GLP-1 than the SGLT2. The baseline estimated GFR, 76 and 78. The 2 classes of drugs did not differ in the metabolic outcomes with regarding the change in hemoglobin A1C. They have the same hemoglobin A1C at the end. Hemoglobin A1C changed in -0.6 and -0.4. Both of them was not statistically different between both of them. And very elegantly, the change in weight, it was -2.2 in the GLP-1 receptor, -1.6 kilos in the SGLT2. So it was only no statistical difference between weight loss in both studies, the GLP-1 and the SGLT2. What about the cardiovascular outcomes? The predefined characteristic of the clinical MACE was similar. In all of them, 3-point MACE, all of know now, cardiovascular death is non-fatal MI, non-fatal stroke. The ELEXA trial of the lexazenatide has included 4-point MACE with the addition of hospitalization of heart failure. There was no difference in rate of MACEs between both groups, as we even in the observation study. There was no difference in the rate of cardiovascular deaths between the both groups, as also apparently in the previous observation study. But the rates of hospitalization of heart failure is another measure of secondary endpoints, did not show improvement with the addition of GLP-1. Again, that's what been observed in the previous observation study, but did show improvement with the addition of SGLT2. So definitely, yes, SGLT2 has a difference important in improving the hospitalization for heart failure. And this difference was very important between the both classes, and both of the trials have been approved this. The benefit of SGLT2 were accentuated with the severity of the underlying disease cohort for MACE, cardiovascular deaths, and hospitalization of heart failure. This is a very important issue. They found that the SGLT2 were more beneficial with the severity of the atherosclerotic cardiovascular disease. And the improvement in cardiovascular death rate was predominantly seen in patients with which the control population had a cardiovascular event rate greater than 10 events per 1,000 patients per year. For treatment of GLP-1, this was not apparent. What about the renal outcomes? The studies on the renal effect had adjudicated outcomes in the GLP-1 and 4 SGLT2 studies, and in the other renal events were considered only as an adverse event. The criteria for projected renal events varied among the studies, including new onset microalbuminuria, doubling serum creatinine, requirement for renal replacement therapy, or death from renal causes. However, other studies used other surrogates endpoints like either decrease in estimated GFR or decrease in the eGFR by 30 to 40%. In SGLT2 studies, varied in duration and starting estimated GFR may contribute to an endpoint of doubling estimated GFR. Both classes of medicine improved the outcome of renal major adverse event compared to control. So both of them has the same benefit on the renal outcomes. There was no difference, however, between renal outcomes between both classes, nor a statistical difference in the number to treat to prevent any renal events. And they concluded from this study that both GLP-1 and SGLT2 reduced MACE, cardiovascular deaths, with neither class superior to the other. However, there is clear benefit in SGLT2 in reducing hospitalization of heart failure than GLP-1. This is added to the previous observation study. And when the data were stratified according to the severity of cardiac diseases, this is very important. Subject treated with SGLT2 class benefited more in terms of reduction of 3-point MACE cardiovascular deaths, reduction of hospitalization of heart failure in patients with greater severity of illness, as determined by the major adverse cardiovascular events. When examining renal benefit, both classes had the same associated improvement in account. And whether SGLT2 is superior than GLP in this setting is not clear. So our finding of this meta-analysis modifying the current ADA recommendation to guide clinicians towards the use of either GLP-1 or SGLT2 in patients with type 2 and cardiovascular risk has been already mentioned 2020, but preferentially encourage the use of SGLT2 for those patients with heart failure and more advanced cardiovascular disease. Does SGLT2 have theoretical benefit of renal protection as demonstrated prospectively in the credence, which provide sufficient evidence for FDA approval for indication for renal protection. And only the leader and rewind of the liraglutide adjudicated renal events, although there was no preferential benefit of SGLT2 class compared to GLP-1 in renal protection. The two classes of drugs need to be analyzed either to head-to-head trials or retrospectively through the primary source document using common definition of adverse renal events. And thank you.
Many thanks for Professor Ibrahim Al-Abrashi for your elegant, clear, impressive talk. In fact, although the randomized سامعني حضرتك؟
سامعك دكتور.
Although the randomized controlled clinical trials is still the best way to evaluate the different glucose-lowering agent and compare each other, real-world studies may confirm or even add to this randomized controlled trial in the real way. In fact, Dr. Ibrahim Al-Abrashi, you highlight the superiority of HGLT2 inhibitors versus GLP-1 agonist for management of diabetes mellitus in this real world study. I think that this real world study confirm or come in agreement with the algorithm 2018, which put the HGLT2 inhibitor as a preferred agent for treating diabetic patient with type 2 diabetes who have predominant heart failure or chronic kidney disease. And they put the alternative GLP-1 agonist if the patient can't tolerate the SGLT2 or the glomerular filtration rate is not adequate. So I think that this real world study confirm what is present in the previous algorithm. Many thanks for you again, Dr. Ibrahim Al-Abrashi. I don't know if there is any question. Ahmed? So I'd like to ask you, Professor Ibrahim Al-Abrashi, about this era of COVID-19. As you know, about 80% of these patients have no symptom at all. And many of our patients, in fact, controlled in combination of metformin with HGLT2. Do you think that if the patient controlled on this combination, it's not the time to change the patient to another glucose-lowering agent, except if the patient got the infection, or it's better to change it before the patient gets the infection?
Very important question, Atif, because we are in a situation we are dealing with a lot of patients diabetic with COVID-19. Actually, all the data, and they have already panelists for treatment to put recommendation for treatment of diabetes, pre-diabetic patient infected by COVID-19. They are talking about if the patient is mild case, not in hospital, nothing problem, without any metabolic arrangement, continue on the same any medication. But if the patient is symptomatic, moderate to severe, or in hospital, metformin should be stopped because lactic acid will be increased. SGLT2 will induce dehydration. GLP-1 will make anorexia. So, and DPP-4 inhibitor could be used because a lot of data could be theoretical or not. One of the receptors entering the cell or inducing inflammation is the DPP-4 enzyme by this virus. So blocking this enzyme could be beneficial, but at least they are safe. So in the patient mild, asymptomatic, controlled, nothing to continue on any medication. If moderate to severe or in hospital, all of them should be stopped. Only can be continued at DP4 and only insulin therapy.
Thank you, Professor Ibrahim Al-Abrashi. This means that a symptomatic patient, even if he got infection with COVID-2, no need to change his treatment. This is good. Yes. Yes. Much thanks, Dr. Ibrahim, for your elegant, clear, impressive talk. Thank you.
And now we going to the last speaker of our day. We have our colleague, Professor Khalifa Abdallah, Professor of Internal Medicine, Diabetes, and Lipidology Units in Alexandria University. The lecture will be titled SGLT2 Inhibitors, Moving from Neutrality to Benefits. Please, Dr. Khalifa.
Good evening, everyone. Actually, I am really honored to join you today in this meeting. And within nearly 30 minutes, I'm going to talk about the benefits of SGLT2 inhibitors, concentrating on the dapagliflozin in particular, because we are in AstraZeneca sponsored symposium. So we all know that just being a diabetic, just being a patient with type 2 diabetes increases significantly your risk for microvascular complication, kidney, eye, and neuropathy, significantly increases your risk for myocardial infarction, stroke, and heart failure. Don't forget that 2/3 of type 2 diabetes patients die from cardiovascular disease. And our main objective in diabetes management is to delay or prevent cardiovascular disease in type 2 diabetes. So, Dr. Salah, please close your mic. So, you know, the central role for in cardiovascular and renal disease can be summarized into 3 parts. The heart as a pump, and the vessels, blood vessels leading to atherosclerosis and infarction or strokes, and the filter, meaning the kidneys. So, affection of the cardiovascular system can affect one of these 3 systems. Don't forget, again, that heart failure is actually the commonest cardiovascular complication of diabetes, not myocardial infarction, not angina. Heart failure is the most frequent cardiovascular complication of type 2 diabetes, and heart failure in diabetes can occur either secondary to atherosclerosis, meaning patient with diabetes with cardiovascular risk factor leading to ischemia or myocardial infarction, and then pump failure. Usually this kind of heart failure is in the form of heart failure with reduced ejection fraction. However, even in the absence of atherosclerosis, in the absence of coronary heart disease, patients with diabetes have increased risk of heart failure, and this is called diabetic cardiomyopathy. Actually, there is several pathophysiological mechanisms leading to diabetic cardiomyopathy. I'm not going to go in depth, of course, for this pathophysiological mechanism. It takes a lot of time for discussion, but just mentioning the advanced glycation in the products, the increased tendency for myocardial fibrosis, the enhanced renin-angiotensin system, impaired calcium handling, endoplasmic reticular stress, altered insulin signaling inside the heart, oxidative stress, inflammation, and so on, increased apoptosis, and so on. So there are so many interplaying factors that can lead to heart damage in type 2 diabetes in the absence of coronary artery disease. That's why heart failure is a very common complication of diabetes and should be looked for, because sometimes the symptoms is vague and you usually miss the diagnosis, because this patient may just saying, I feel just fatigued, I have dyspnea on exertion, and you can attribute that to the overweight, to the age, and so on. Please look carefully for the presence of heart failure in patients with type 2 diabetes. The other thing, kidney disease in diabetes is very common. It's one of the major complications of diabetes. And usually, affection of the kidney and affection of the heart in a diabetic patient occurs more or less simultaneously, because the factor leading to heart disease and kidney disease are common in several pathways, whether inflammation, RAS system activation, ischemia, hyperglycemia affects both. However, if one of the systems is affected, for example, kidney disease and diabetes leading to salt and water retention, hypervolemia, anemia, and so on, will affect the heart and may be a contributing factor in heart failure in diabetes. And on the other hand, heart failure with reduced cardiac output may affect the kidney. So usually we look for both cardiorenal system as one unit when we are treating our diabetic patients. Now, do SGLT2 inhibitors cover the pump, the pipes, and the filter? I mean the heart, the vessels, and the kidney. Let us see the data from the cardiovascular outcome trials in diabetes. I don't want to mention that because you all know cardiovascular outcome trials started after the guidance for industry from the FDA to tell companies you have to do trials to prove safety of your drug given to a diabetic patient after the what happened with rosiglitazone. So most of the trials, the aim was to prove safety, not superiority. But fortunately, some of these trials, some of these drugs showed us that there is superiority, not just safety for the cardiovascular system. Starting with the DPP-4 inhibitor trials with saxa, allogliptin, and sitagliptin, they proved to be safe for the heart, but there is no superiority. Of course, you know, saxagliptin in the trial of SAVOR-TIMI trial, there is increased tendency for hospitalization of heart failure, but overall, the meta-analysis of the 3 trials, there is no significant deleterious effect on the heart. That's why they are safe to be used as anti-diabetic medication in type 2 diabetes. However, let us see evidence from the SGLT2 inhibitors, the empagliflozin, canagliflozin, and dapagliflozin in the EMPA-REG trial, CANVAS trial, and DECLARE trial. Don't forget that the baseline characteristic for the population in the trials is different. For example, in the EMPA-REG, all of the patient, 99% of the patient had already established cardiovascular disease. In CANVAS, the 2/3 have established cardiovascular disease and 1/3 just cardiovascular risk factors. But in DECLARE, 2/3 have just cardiovascular risk factors and no cardiovascular, 60%, no established cardiovascular disease. That's why when you read the trials, please note the differences in the patient population. In the EMPA-REG trial, empagliflozin on top of usual care reduces significantly the primary endpoint, 3-point MACE, non-fatal myocardial infarction, non-fatal stroke, and cardiovascular mortality. And this was really astonishing. For the first time, there is a drug that can reduce cardiovascular complications in patients with type 2 diabetes. It also showed that there is a 38% significant reduction in cardiovascular mortality and 32% reduction in all-cause mortality. And again, very, very important endpoint, hospitalization for heart failure was reduced by 35% significantly. This is the EMPA-REG outcome trial, which have changed the guidelines and changed our way of thinking regarding choosing anti-diabetic treatment in patients with high risk or established cardiovascular disease. Again, the benefit was confirmed with the CANVAS program using canagliflozin. And again, in this population, there is a significant reduction in the 3-point MACE by 14%, and again, 33% risk reduction of hospitalization for heart failure. And in canagliflozin, as I said, 2/3 of the population of the study have already established cardiovascular disease, and 1/3 with just multiple risk factors. In both trials, empagliflozin and canagliflozin, not only heart failure and cardiovascular adverse events was significantly reduced, but also the renal endpoint, renal outcome, was significantly reduced by 46% in the EMPA-REG and 47% in the CANVAS program. Renal endpoints meaning doubling of serum creatinine, end-stage progression to end-stage renal failure or renal death. This is hard endpoints that have been improved by using this class of drugs. Coming back to the third trial, DECLARE trial, I mean. If you look here, the light blue, meaning patient with just multiple risk factors and no established cardiovascular disease. 60% of the patient in the DECLARE study has just multiple cardiovascular risk factor, meaning this population at low risk for cardiovascular disease compared with patients with established cardiovascular disease. And we know from several previous studies in general that the higher the baseline risk, the more frequent that the benefit can be shown within a short period of time. So the importance of the DECLARE study is showing the benefit of this class of drugs as a primary prevention in patients without established cardiovascular disease, because this population is the majority of our population in our daily clinic. Look carefully to this slide in front of you. Again, this figure, this is the proportion of patients with different categories of estimated glomerular filtration rate. In violet, the DECLARE, in DECLARE study, patient with estimated glomerular filtration rate below 60, that's to say advanced stage of kidney disease, compared with patient above 60 and so, was just 7% in the DECLARE, compared with the EMPA-REG and the CANVAS program, meaning that the renal status of the population of the DECLARE study was much better than patients in the other two studies. Again, we know that when you have deterioration of the kidney function at baseline, that these patients at higher risk of cardiovascular disease again, meaning that the population of the DECLARE study was at a lower risk from the start. This is important when you try to do some interpretation of the results and to compare different studies together. However, with this background, low-risk individual, it has been shown that giving dapagliflozin was associated with reduction in the 3-point MACE. However, this reduction was not statistically significant. However, the co-primary endpoint, that is hospitalization for heart failure or cardiovascular death, was reduced by 17% significantly. This is the primary endpoint. The 3-point MACE, there is tendency for a reduction, however, by 7%, but was not statistically significant. Regarding the renal endpoints in the DECLARE study, and again reminding you that 2/3 of these patients were having just having cardiovascular risk factors, the renal endpoints, the hard renal endpoints, which is a composite of more than 40% reduction in estimated glomerular filtration rate to reach below 60, or progression to end-stage renal failure or renal death, was significantly reduced by 47%, confirming the same figure with the other two molecules. That's why now this class of drugs is definitely a renoprotective class of drugs for diabetic individuals. If you go to the components of renal endpoints, whether a patient progressed from normal to microalbuminuria or from micro to macroalbuminuria, and so all these endpoints was significantly reduced by using dapagliflozin in DECLARE study. How about if you analyze within the DECLARE study patient with already established cardiovascular disease? We said that 40% of the patient have established cardiovascular disease and 60% just cardiovascular risk factors. This is a sub-analysis of the DECLARE study showing the effect of dapagliflozin in patients with previous myocardial infarction. There is nearly 3,584 patients in the DECLARE study have a history of myocardial infarction. When they did the analysis, statistical analysis for this patients with previous myocardial infarction, it has been shown that dapagliflozin reduces the primary endpoint MACE by 16%. And this reduction was statistically significant, confirming again that this class of drug as a whole reduces MACE in patients with established cardiovascular disease. Again, a sub-study in the DECLARE study showing patients who had at baseline heart failure, history of heart failure with reduced ejection fraction. 10% of the population of the DECLARE study had heart failure with reduced ejection fraction. How about the outcome in this individual? It has been shown with dapagliflozin in this group or this population of patients with reduced ejection fraction heart failure, the hospitalization of heart failure and cardiovascular mortality was reduced by 38%. And the number needed to treat within 4 years is just 12 to save one event. Hospitalization of heart failure was reduced by 36%. Cardiovascular death was reduced by 45%. And all-cause mortality was reduced by 41%. Look to the number needed to treat, and you can see how important in this group of patients with reduced heart failure, dapagliflozin was significantly reduced major cardiovascular endpoints, heart failure up to death. And this is, I think, a very important sub-analysis of the study. About the cardioprotective effect in primary prevention, those without heart failure, those without previous myocardial infarction, or just with multiple risk factors. It has been shown that dapagliflozin in the DECLARE study reduced the incidence of hospitalization for heart failure significantly by 27%. This is evidence for primary prevention, diabetic patient without history of cardiovascular disease, giving this class of drug benefit from reduction in the incidence of heart failure, which is a common complication, as I said, of type 2 diabetes. This reduction in heart failure, hospitalization for heart failure, has been shown irrespective of the baseline characteristic of the patient, meaning patient with multiple risk factor or patient with established cardiovascular disease, they both showed reduction in hospitalization for heart failure. And also, if you look to the history of heart failure from the start, patient with history of prior heart failure or no history of heart failure, both showed significant reduction in the incidence of heart failure. That's, you can say from this result that dapagliflozin can protect the patient from heart failure even in the primary setting without a cardiovascular history of cardiovascular disease. And that's why in October 2019, the FDA approved dapagliflozin to cut risk for hospitalization for heart failure in type 2 diabetes, stating that dapagliflozin is used not only for the management of diabetes or controlling blood glucose, but to decrease the risk of heart failure, and according, as they said, to the finding in the DECLARE TEMI 58. How about the renal outcome? Again, as I said, there is a significant reduction in the composite endpoint for renal outcome. with dapagliflozin is a DECLARE study. If you look to this benefit, it was clear and apparent in all subgroups, whether the patient from the start has a normal kidney function with estimated glomerular filtration rate above 90, or the group of patients with mild renal insufficiency between 60 to 90. So it's also, again, a primary prevention strategy to save the kidney. And also the benefit was shown whether the patient have established cardiovascular disease or, again, multiple risk factors. So the renal benefit is there. The heart failure benefit is there, whether the patient is having established cardiovascular disease or not. If you look to the progression of the renal function by the estimated glomerular filtration rate in this figure, you can clearly see that at the beginning of treatment, there is a decline in the glomerular filtration rate by using dapagliflozin. Actually, this is a sort of hemodynamic adjustment, as usually seen also with RAS inhibition when you give it to protect the kidney. And after that, with time, you can see that the rate of decline is in the estimated glomerular filtration rate is less with dapagliflozin compared with the placebo after 4 years of the study. So about the safety, comparing DAPA with placebo, actually, there is no significant differences between the group, except, of course, for the increased genital infection, which is characteristic for the whole group and can be easily treated and managed. Now, according to this finding, the guidelines have changed, as we already heard today and yesterday from our eminent speakers. And that's why I'm going to pass quickly through these slides. The ADA Standard of Care 2020 saying that first-line therapy is metformin with lifestyle modification, and then you have to see your patient. If there is your patient in front of you has high risk for cardiovascular disease or already have established cardiovascular disease or kidney disease or heart failure or not. If not, you can choose any of the anti-diabetic treatment you are going to use. If the patient have high risk for cardiovascular disease, kidney disease or heart failure, you have to consider either SGLT2 inhibitors or GLP-1 receptor agonists. If the risk towards atherosclerosis, that's mean coronary heart disease, myocardial infarction, cerebrovascular disease, stroke, the evidence is with GLP-1 receptor agonist. If the increased risk or the history of heart failure or chronic kidney disease, meaning even albuminuria, you have to choose, the best is to choose SGLT2 inhibitors, irrespective of the A1C. We are not giving these drugs to control diabetes in this situation. I can say it's a compelling indication. It's the same as you are treating a patient with hypertension and you are using beta blocker. It is not, of course, one of the drugs that should be used in general. However, there is compelling indication for their use. Here is a compelling indication of the drug. Just think, even if they don't reduce the blood glucose, you are giving these drugs to save your patient. So add it on top. Use metformin with one of these drugs according to the cardiovascular risk of your patient. If not, these drugs can be used also to manage diabetes because, of course, if you are afraid of hypoglycemia, they don't cause hypoglycemia. If your weight gain is of concern, they don't increase the weight. On the other hand, they decrease the weight. That's why this class of drugs can be used even without cardiovascular risk as an unsafe and beneficial anti-diabetic treatment. The European Society of Cardiology guidelines, you heard this yesterday, they stated that if the patient has high cardiovascular risk, you can start this medication as a monotherapy from the start. The diabetes point of view, we actually don't adopt this pathway. We add this drug on top of metformin because using two drugs from the start is definitely will be associated with a prolonged glycemic control, and you take the benefits of the two medication. I'm not going to discuss in details the mechanism of action of these drugs because you definitely know the mechanism by inhibiting sodium and glucose reabsorption of the kidney. That's why glucose and sodium passes through the kidney. This will lead to glycemic control because excess glucose is passed out, independent of the beta cell function, independent of anything, just the excess glucose is passing down. When you lose energy as a glucose in urine, definitely you are going to lose weight. And when you lose sodium, passes sodium in the urine, excess sodium with the glucose, then the blood pressure will be reduced. So these are traditional risk factors in complication of diabetes: blood pressure, body weight, and glycemic and blood glucose. The three parameters will improve with the use of SGLT2 inhibitors. If you look to the data of dapagliflozin regarding the glycemic efficacy, A1C reduction, you can see used as monotherapy on top of metformin, on top of sulfonylurea, on top of DPP-4 inhibitor, on top of even of insulin. There is a consistent reduction in A1C, whether used as a monotherapy or on top of any medication you can give. The only contraindication is patient with significantly decreased estimated glomerular filtration rate below 45. That's why when you compare dapagliflozin with saxagliptin, for example, you are going to see better A1C reduction with significant weight loss and blood pressure, systolic blood pressure reduction compared with compared with saxagliptin. How these classes of drugs protect the kidney and protect the heart, this is definitely a very a huge subject. And if you go to the literature in the internet, you are going to see a lot of explanation, pathophysiological mechanism, but we can say now, still, it is not clearly defined. All are just hypotheses and just a sort of theories explanation leading to trying to explain why these drugs can protect the kidney and the heart. For example, in the renal protective mechanism, they said that SGLT2 inhibitor reduces glomerular pressure by adjusting the glomerular feedback mechanism. They improve the neurohormonal parameters by decreasing the RAS activation and decreasing the sympathetic nervous system activity. They have anti-inflammatory, anti-fibrotic properties. They also increases renal oxygenation and so on. These proposed mechanisms stabilize the estimated glomerular filtration rate and decreases the blood pressure, protect the kidney from renal ischemia, and so on. Together will lead to renal protection. Of course, each of these proposed mechanisms can be discussed in hours. Regarding the heart, is the same. Some proposed mechanism reducing preload and afterload. This is, of course, can be explained due to loss of sodium in the urine. It improves myocardial energy utilization within the myocardium and also cardiac remodeling. And this proposed mechanism can improve cardiac contractility and can protect against heart failure. not only dapagliflozin improves or protect the heart and the kidney in patients with type 2 diabetes, but actually these results led to further investigation or trials to see the effect in non-diabetic individual, because the mechanism of protection is away from glycemic control. So it is reasonable to think how if we give these classes of drug to non-diabetic individuals. So we know the DAPA heart failure trial, that dapagliflozin significantly improved all the endpoints in patients with heart failure with reduced ejection fraction. This is DAPA heart failure, whether the patient is diabetic or not. Now we are waiting for the results of DELIVER trial using dapagliflozin in patients with heart failure with preserved ejection fraction, and also DAPA-CKD, which is effect of dapagliflozin on patients with chronic kidney disease, whether diabetic or not. So this is my slide to conclude that you have patients with type 2 diabetes coming to you with just multiple cardiovascular risk factors. This is the usual 4 out of 5th of your patients, 80% of your patients, or 1/5 of your patient may come with established cardiovascular disease. Using these drugs, class of drugs, dapagliflozin or SGLT2 inhibitors, in all diabetic patients, can significantly protect the kidney and significantly decrease the risk of hospitalization of heart failure, irrespective of the presence or absence of established cardiovascular disease. However, for MACE reduction, that's to say major cardiovascular events, only patient with established cardiovascular disease can benefit from this protective effect with SGLT2 inhibitors. Don't forget, majority of your patients at high risk for cardiovascular disease, for heart failure, for kidney disease. I think in the near future, these drugs will be given for the majority of type 2 diabetes to save their kidney, their heart, and their lives. And thank you for your attention.
Thank you, Professor Khalifa, for this clear, elegant lecture showing the benefits of using the group of SGLT2 inhibitors. Thank you.
Thank you.
Thank you for my colleagues, all professors, give us very clear lectures in this second day. I think also it is a successful day of learning about the new guideline and its implementation in different types of patients with type 2 diabetes. And as I said, we get the credit from the American Association of Continuous Medical Education, and we have a good score for this. And we are waiting all the attendance in our second wave, which will be, inshallah, 6 and 7 of August this year. Thank you again for all, and see you, inshallah, soon.